For those watching from around the world, Cliff Rosendahl is one of those rare people whose work you've probably used many times, even if you didn't realise it. Cliff is a clinician, educator, researcher with over 100 peer-reviewed publications, and is best known for developing the chaos and clues approach, a framework that helped countless clinicians move from that uncomfortable "I'm not sure" feeling to safer, more structured decision-making. He's taught thousands of doctors around the world, from dermatologists to busy GPs, and I particularly want to thank him for everything he's contributed to dermoscopy in primary care, where this work really matters in everyday clinical practice. Cliff, I'm looking forward to our discussion and presentation this morning, or rather evening in Australia. I've lined up a few questions to get us started, but really wanted to serve the needs of those listening. So please, folks, do add questions in the chat and we'll weave them into the discussion as we go. For those of you joining us live, this is a rare chance to ask questions and quiz a master, and a very warm welcome as well to everyone watching later on Catch Up. And just before we start, Cliff's second edition Dermatoscopy book is now out, and for you lucky people, there's a 35% discount code you can use when purchasing it using the link in the chat discussion and description. As a bonus, there are also 2 freely downloadable PDFs that will guide you through the chaos and clues and pigment approach to lesion diagnosis. Cliff, it feels like Christmas already. Thank you and welcome.
Thank you, Andy, and thank you for that lovely introduction. And it's really my pleasure to be here, whatever time it is in whatever part of the world people are. So I'm going to go to share my screen. So here we go. It's sharing. You've already achieved that. That's fantastic. Brilliant. Now I'm going to go to a slideshow. So is that up for you now, Andy? And
yeah, that's
everybody
perfect.
Else?
Already locked and loaded.
Fantastic. So this is from down under, and it's all about hunting. And that image sums it all up. There's a hunter. That picture's taken back in 1988. And that hunter could only find what he was hunting with the use of a face mask, because without a face mask, everything under the water is blurry. And it's very important to be able to distinguish a morwong, which this is, from a great white shark or a tiger shark, because some things you need to show more respect. But this morwong was fair game, and that was a good day's hunting. Now, I'm in Australia, right? And I'm actually on an island off the east coast of Australia. And Andy, you're in England.
I am.
And I checked on Google, that's 16,500 kilometres away.
Wow.
And it's just as if you are here in the same room, which is amazing. Now, there is a map of Australia, and you can see Brisbane is on the far east, and furthest away from England than the rest of Australia. Yeah. And when you see a map like this, the hair should rise on the back of your neck. This is a map of Australia etched by malignant melanocytes on the jaw of an Anzac veteran, Australian New Zealand Army Corps veteran who fought in World War II. You will never see a nevus that looks like a map of a country. And this is a useful sign, which we'll touch on a bit later. This is another map of Australia. This is from the Australian Cancer Atlas. It's a heat map of melanoma incidence. Where it's red is where the highest incidence of melanoma diagnoses are made. And I'm right there. And so what we're looking at here, where I am, is the highest incidence of, or highest diagnostic rate of melanoma on the planet.
Wow.
So I get to see a lot, and that's a privilege for me. And I enjoy sharing that with people. That's my boat. That's how I get to work. I live on an island. You can see my house in the background there. And in my front yard, I've got to watch out. I don't bump into things like that. Let's say a whale, and it's you can see my rowboat in the background there that I row
Cliff,
out.
Cliff, I've got 2 goldfish in my pond, not quite like your pond.
Goldfish, yes. Well, goldfish can be very, very frightening for amoebas. So I guess it's the context that matters, isn't it? It's the context. Now, here's my journey over 50 years, 48 years, from 1976 to 2023. And what you're seeing there is my melanoma diagnoses for each year. And you can see for the first 30 years, I didn't find a lot of melanomas. I had just as many people die in that 30 years from those melanomas as I had in the last 18 years, from where you can see the green bars. But there was something that happened that started my journey. This is a photograph taken in 1969. That's my sister and her boyfriend, Graham. And they were in love and they got married. And then around about 2000, Graham got a lesion on his thigh and his GP dismissed it. And I tell that story in the preface to the first edition. So Graham developed metastatic melanoma. He did not blame the GP who dismissed a lesion of concern on his thigh a couple of years earlier. And he made the point to me that GPs were not prepared for this challenge in their training. A challenge that was thrust on them due to the rising incidence of melanoma and an inexplicable shortage of dermatologists. We only have about 500 dermatologists in Australia for 26 million people. We have 30,000 GPs. And so GPs manage most of the skin cancer, most of the melanomas by default. Now, that's where Graham had his metastatic melanoma and died very rapidly from that. And his GP looked after him till the day he died, and he never blamed that GP. And that GP still looks after my sister. But you can see that triggered a response from me. I purchased a dermatoscope. I started finding melanomas. And in 2009, when I was 2008, when I was 59, I started my PhD, and it went from there. Now, you're going to ask me what I feared most, Andy, and this is the response. The thing I fear most in my work is missing a significant melanoma in a young person. Now, a person like me, got 6 kids, 9 grandkids. If I fall over tomorrow, the world will go on. This young lady, 37, had 3 little children at this time. And she presented, and in her examination, we encountered a red spot on each thigh. So we examined those with a dermatoscope. First of all, these are the close-up images of each of those red spots. So have a look at those and tell me if you think there's anything that makes you alarmed about either of those. And these are the dermatoscopy images. Now, when I first started using a dermatoscope, I was amazed at how much more I could see with a dermatoscope. And you can see there, for what looked like pretty similar lesions clinically, they're dramatically different dermatoscopically. So we'll put this through prediction without pigment, and you all can have access to a PDF of this algorithm from Andy. He'll show you how to.
It's in the comment section, and I'll put it at the bottom of there so people can download it free. Thanks, Cliff.
Fantastic. And the first thing we do is we decide if the lesion is a lesion of concern. We don't put everything through the algorithm. Now, how we decide that is we examine lots of obviously normal things. And the 5 lesions that are common benign lesions that will 99% of what you encounter in general practice will be one of these 5. The first one is nevus, and these are the non-pigmented varieties, right? An amelanotic nevus. The second one up here is a seborrheic keratosis. The third one is a dermatofibroma. The fourth one is a hemangioma, and the fifth one is sebaceous gland hyperplasia. Now, you look at the lesion, you say, can I give this a pattern recognition diagnosis of any of those 5 things?
Yeah.
And it's pretty easy because that's the example I've actually used up at the top. This particular case of a clods-only pattern, a clods-only pattern. Now, note that the clods-only pattern can have a few linear variants at the edge and a small hemangioma.
Yeah.
That doesn't negate the clods-only pattern, but it must never have linear vessels inside red clods.
Yeah.
Okay, otherwise it could be a melanoma. So this is a clods-only pattern. It's a hemangioma. We don't put it through the algorithm. Now, the other lesion on the right thigh, we can't give it a pattern recognition diagnosis of any of these things up here. They're the only ones you've got to remember. You can't. So first of all, you look to see, is it ulcerated? Can you see any ulceration there, Andy?
No, I can't, no.
Okay.
Yeah.
Step 2, are there white lines?
Well, there might be some white lines. Is that polarized or non-polarized?
Yeah, this is polarized, and there's some white lines here.
Yeah, down the bottom there, a little bit of fluffy cloud. Yeah.
So here, can you see them when I press here or when I press here? When I press on the image?
Yeah, I can see your thing. Yeah.
You can see my cursor there?
Yeah, no, there are some there.
Good. Okay, so that we cut it out. It's as simple as that.
Right.
If it didn't have white lines, you then look for keratin clues on a raised lesion, which is surface keratin, white circles, white structure areas, and they would point to SCC. And if it didn't have that, you'd look for vessels. And there are 4 benign patterns of vessels here. And if it's one of those, it's benign. If it's not, you cut it out. But we only got to white lines, so that's as far as we have to go. The beauty of this algorithm, when you get to one of the 4 that's positive, that's as far as you have to go.
Cliff, what I love about it from a general practice point of view, you're quite right. We see so much benign stuff, don't we? So SEB-K, capillary hemangioma, dermatofibroma, intradermal nevi, which are often pink and floppy and soft wobble positive. And if once you learn those things, which ultimately just takes a little bit of practice, you're 90% there, aren't you?
Well, you see a lot of those things, so it's very easy to become an expert at recognizing the common benign things because you see many of them every day. That's the important thing. It takes a long time to see 1,000 melanomas, but it only takes a week to see 1,000 nevi.
Yeah.
Once you're an expert at recognizing the benign, you know when something's not benign.
Yeah.
Then you've just got to work out what to do with it.
Right.
And that's what the algorithms are all about.
Yeah. Okay.
Now, this one has white lines, consider biopsy. So there are the options, BCC, melanoma, blah, 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 blah. And this was a nodular melanoma with a Breslow thickness of 0.8 of a millimeter.
Yeah.
It's in the book. Now, that's a significant Breslow thickness because when you have a melanoma with a Breslow thickness of less than 1 millimeter, the 20-year disease-free survival prognosis is 96%. Once it goes over a millimeter Breslow, that goes down very sharply.
Right.
So to get this in a 37-year-old, at this stage, and this diagnosis was made 10 years ago, she's doing fine.
Good.
And with 3 little kids, well, they're not so little anymore. And they've had their mum. That's the important thing. Now, I want to show you here the first image which is C. Now, can you see my cursor there, Andy?
I can. Yeah.
That's the same lesion, but there's no white lines.
Right. No.
Non-polarized.
Yeah.
This is the same lesion, D, and it's also now with a polarized dermatoscopy. You can't see any white lines.
No.
That thing there is a hair.
Yeah.
You can see a 4-dot clot or a rosette, but that's not a sign of malignancy. You had to rotate the dermatoscope to see the white lines.
Yeah.
So even with the polarized mode, unless you'd rotated this dermatoscope, you may have missed those white lines.
Yeah.
Now that's important.
Yeah.
Very important.
Do you know what, Cliff? When I first started dermoscopy, it must have taken me 12 months to, it's a simple thing, isn't it? Polarized, non-polarized, polarized sees a little bit deeper, non-polarized, you need the contact medium or you can't see it. And it's amazing how long it took me just to automatically think like that and say, right, what changes when I switch? And that's why I think you need a dermoscope that can easily toggle, blink from one to the other, isn't it?
It is, and it's important to do that. But what you've got to really realise is that you will start in the polarised mode by default, because that's how
Right.
the dermatoscopes start.
Yeah.
That's important because you don't actually need fluid interface in the polarised mode.
No.
As soon as you flick to non-polarised, you must put fluid on the skin.
Yeah.
I use alcohol hand wash gel.
Yeah.
It's great.
Yeah.
But there's no point in you looking at it non-polarised without the hand wash gel, without the fluid interface.
Sure.
Now, this here shows an example that we published of a melanoma that could not be diagnosed without polarised dermatoscopy. We have a clot pattern congenital nevus on the left.
Yep.
Here we have a melanoma arising in that congenital nevus, which is not visible in the non-polarised, but it's visible in the polarised mode because of the polarising specific white lines. Now, here's something interesting. See the terminal hair? See the terminal hairs? They're arising from the dermal nevus because the dermal nevus has a hamartoma, and it'll often have terminal hairs that the ladies pluck out when they're on their chin, right? But the melanoma that's arising in the dermal nevus has no terminal hairs. That's interesting. You know, the most likely nevus to have a melanoma arise in it is a dermal nevus, not a dysplasia nevus.
And that really amazed me, Cliff. You know, the figure I remember, correct me if I'm wrong, that melanomas, 80% arrive new, de novo. But when the 20% do arise, I used to think they used to arise in the atypical nevus. But you're saying it's actually more likely in the intradermal, the common.
It is now known that it's the dermal nevus is the most likely. Can you tell if Simon Clark's on our audience? Can you see who's there?
He can type in.
Simon, if you're there, just put in a chat because Simon is an expert. He's a dermatopathologist.
Yeah.
You met him in Belfast.
Yeah.
And I'd get him to comment, but he can comment on that in a minute. Now, this was an interesting paper which was published by Chin Wybrew, who is one of your GPs in the UK. You'd know her.
I know Chin, yeah.
And this is when we discovered that there was a problem with a particular dermatoscope. It was the Heine Delta 30. And it didn't show polarizing specific white lines. You can see here, all these dermatoscopes. On the left-hand side, you've got polarized, right-hand side, non-polarized. And you can see they've all got these polarizing specific white lines, except the Heine Delta 30, where the polarized and non-polarized look the same.
Yeah.
And when we pointed this out to Heine, they didn't see it as much of a problem, so we published it. And this is the publication.
Yeah.
And this is the image from the publication.
Yeah.
And in response to that, they developed the Heine Delta 30 Pro, and it's fine.
Okay.
It's fine.
The
Heine Delta 30, I advise you not to spend your money on it.
Yeah.
If you want a Heine, they're an excellent dermatoscope. Buy the Heine Delta 30 Pro.
Yeah.
It shows polarizing specific white lines very well.
Cliff, just talking about shiny white lines and things. When I first started, I didn't realize how important they were. And the more I read about it, I call them start worrying structures. Yeah. Shiny white structures, start worrying structures. Because as soon as I see them flash up, I think, something's going on in the dermis. There's new collagen being formed. Is it a scar? Is it a dermafibroma? Or is it a melanoma? Would that be reasonable?
Yeah. And look, shiny white lines and these polarizing specific white lines, which are shiny, white at right angles to each other, but not crossing, right? No. They're not always associated with malignancy.
No.
But in the context of something which might be a nevus, if they're there, it's either a spitz nevus, a traumatized nevus, or a melanoma.
Right.
A normal nevus won't have polarizing specific white lines.
Right.
They're commonly seen in BCC.
Yeah.
They're also commonly seen in dermatofibroma.
Yeah.
You can get them in lichen planus like keratosis, and you can get them on very severely sun-damaged skin. So you always look at the skin beside the lesion you're looking at when you're evaluating any structure.
Good point. Yeah, I like it.
But in a lesion which would otherwise be a nevus, they are a concern. They are a concern.
Right.
And a very, very useful sign.
Yeah.
Now, you asked me if there was a particular moment which was like a eureka moment for me.
Yeah.
And I want to share this one with you because this was, you can see here, a man who's he's probably about the same age I am now. And he had this lesion on his back over his scapula. You can see on the left, the first dermatoscope I bought. It cost me $40,000. It was a Molmax.
Do you know, that's a leap of faith, Cliff, isn't it? That's a leap of faith. I'm going to spend all this money and maybe it's a waste of money.
That's a very generous description of what I did. But you can see here, the images taken with the Molmax, the polarized one at the top, that's how the machine came.
Yeah.
I was so disappointed. I'd actually by this time got a non-polarized camera made. I spent another $1,000. Now this is back in 2005. That's a lot of money.
Yeah.
And I made and you can see a little bit of blue in the non-polarized, but look at the Heine Delta 20. Look at the blue there. That was the eureka moment for me.
Right.
That's when I saw what dermatoscopy was capable of. If you weren't stupid enough to spend $40,000 and just spend $1,000 on a little Heine, what they cost then, and you could get a lot more information.
Yeah.
See what you've been missing. That was my eureka moment.
Yeah.
That and I was so confident in this lesion, I took all those images with different devices and lots of others too, because I knew it would be a valuable case.
I mean, Cliff, when I first started out, it was like scuba diving. You know, you go from this just surface view and it's a new world opens up to you. And when I started off, it was so colours here, patterns there. It's very confusing, isn't it?
And you cut all sorts of stuff out, don't you? You cut everything out because it's all scary.
Yeah.
So when I started, I was cutting out 13 benign things for every melanoma.
Right. Okay.
Because it was so fantastic and everything looked amazing. But now I've got that down to about 2. Right. And that's much, but it's okay to have a learning curve.
Right.
It is okay to have a learning curve.
Absolutely. Yeah.
Now, this is another question you asked me. How long does it take to become competent enough for dermatoscopy of use in primary care? And what skills produce the fastest confidence wins early on? Well, this is Finbar McGrady. And you know Finbar? And this was Finbar in 2013. And Finbar came to a presentation I was doing in 2013 in Brisbane. And he sat there in the audience for an hour and a half. And we did all the normal stuff. We talked about natural forces favoring symmetry. We talked about malignant cells defying natural laws. We talked about grey or blue color, and we explained how the scattering of light by the collagen fibrils in the dermis caused a Tyndall effect, like the atmosphere. Molecules cause a Tyndall effect to make the sky blue on the earth. It makes the melanin blue when you see it in the dermis. Yeah. So he knew that if you saw blue color in a chaotic lesion, that was bad. That was a sign of something bad going on. You're getting information from dermatoscopy of the biological activity going on in the dermis to about a depth of 1 millimeter. This is about how far you can see with a dermatoscope. Yeah. So Finbar came up to me at the end of that 1.5 hours and he said, Cliff, I'm Finbar. And I knew from his accent, which was an Irish accent, that he had a low risk of skin cancer because someone with a name like Finbar McGrady and an Irish accent is pretty safe. Whereas someone like Finbar with a name like Finbar McGrady with an Australian accent, they're in a lot of trouble.
Right, yeah.
Did I bring up that thing, or was that on your end? The next previous blah blah blah. It must have been me. Okay, so and he said I've been in Australia for 6 months. I'm on a sabbatical. I got a bit burnt out in Ireland, and I come out here, and I've been here for 6 months, and I've been looking for melanomas. I haven't found one yet. I said, well, Finbar, you'll find one within the next couple of weeks because you've been here for an hour and a half, and that's all it takes. Yeah. So a week later, I got this email. Hi, Cliff. This guy was worried about a sebcar in his arm. I advised a full skin check and found this. In fact, he said, get your gear off, because that's the Australian way of saying take your clothes off. And he learned a bit of lingo by then. Yeah. And this is what he found. So you can see this guy is this typical Australian back. There's a lot of freckles.
Yeah.
And that's the one he singled out.
Wow.
Gee, it's a bit irregular, right?
Yeah.
And you can see, yeah, it's interesting.
There's
It's
a
tiny.
lot to look at there, isn't there? It's easy to miss that.
Well, 2 millimeters in diameter.
Oh,
2 millimeters.
wow.
Look at the dermatoscopy.
Wow.
Look at the dermatoscopy. So Finbar looked at that.
Yeah.
And he said, step one, can I give it a confidence-specific benign diagnosis?
No.
Now, he only had to worry about the first three, nevus, sebcane, and dermatofibroma, because you haven't got to worry about hemangioma or sebaceous hyperplasia. You've only got to worry about the first three with this one. Okay?
Yeah.
And he couldn't.
No.
So he said to himself, is there chaos? Is it asymmetrical? And yes, the colour's at one end and not at the other end. That was easy.
Mm-hmm.
And then he said, are there any clues? Are there any clues? And when he said, are there any clues? Those were the clues you looked at. And the first one he always learnt to look for is grey or blue colour.
Yeah.
Most pigmented malignancies, whether they're melanomas, BCCs, or SCCs, will have grey or blue colour.
Right.
So there are nine clues there, but the first one is the most important, the most sensitive. And you look at that one before you look for anything else. You always consciously look for blue colour.
Yeah.
Lost my melanoma virginity. It's a bit weird.
Is that a technical term? Cliff, it took me 2 years to lose my virginity. Okay. But I just wonder, as a primary care dermoscopist, when you pick find your first melanoma that you think no one else would have found, is it okay to be excited even though the patient's got a cancer?
It's impossible not to be excited in my experience.
Right.
And it's not, you don't tell the patient, you don't show your excitement to the patient. You can, that doesn't go too well. But it's quite normal, and it's okay, because when you hunt and you get a trophy, it's good. It's good. It's legit. It's a big fish or whatever it is. It's a good thing. I used to hunt wild boar in Australia here. I wouldn't kill a mouse now. Oh. It's an age thing. When you're a young male, you tend to. It's a very natural thing to hunt. I'd still go fishing, spear fishing, but the hunting thing. This is a very legitimate, nature-friendly form of hunting. Yeah. Because melanomas don't have a soul. No. They don't have a soul. No. You don't need to feel bad about taking out a melanoma. Yeah. No. Or a BCC or an SCC, and you're actually saving an individual or saving them from a premature death or from a lot of expensive treatment. So it's a good thing, and it's a good thing to feel good about. So Finbar felt great. And the question was, how long does it become competent? Well, obviously Finbar had been using a dermatoscope. He had some experience looking at benign things, but 1.5 hours for Finbar made the difference. Yeah, wow. And what did he learn? He learned chaos and clues. That's the first thing. And prediction without pigment. They're great algorithms. They came about by teamwork. And I'm very happy to have been involved in both of them. And they're that's very good. I like that. Melanomas don't have a soul, though they can be found on the soul.
Love it. Super. Thanks for sharing that.
Very, you're very fast. Now, I will point this out while I'm talking about this. This is on the poster. Where it says step 3, if you look at it closely, it says, is there one of more of 9 specified clues to malignancy? Suggestion, look specifically for grey colour first. Right. And that means grey or blue. It will be present in most pigmented malignancies. Also, deliberately look for an eccentric structures area. With experience, the other clues should be evident. Now, I won't go into details of what eccentric structures area is. It's in the book. Right. It's in the book. It's in the book. It's in the book. You need the book.
There's a discount. Okay. I think for me, Cliff, with all these clues, I remember when I started and people would talk about network patterns, fissures and ridges and all these things. For me, it's if you're a beginner, it just takes time to pick these things out. Would you agree? So,
absolutely.
For instance, the blue grey colour can be deoxygenated blood in a capillary hemangioma. And just practice will start to tell you the difference. It just takes time.
Yeah, and having a book to guide you is very, very, very helpful. Very helpful. Now, I'll make this point. It's hard to remember 9 clues. I can't remember 9 clues, right? No. I can't. I can remember 2, royal blue structure, eccentric structureless.
Yeah.
The other clues, you will see them if they're there. If there's lines, radial, segmental, if there's white lines, if there's polymorphous vessels, if there's angulated lines, you'll see them.
Yeah.
You won't need to look for them. You need to look for the first clue.
Sure.
So that's how it works.
Good tip, like it.
Now, there we are in 2018.
Yeah.
In Belfast.
Yeah.
And Finbar is now an expert. He's an educator. He is the person I am more proud of than anybody else who's come into my audiences.
Yeah.
I have presented Finbar to 600 dermatologists in standing room only in the Hofburg Palace in Vienna, in the same room that Napoleon proposed to Josephine. I showed these pictures of Finbar up on the stage with his melanoma, and I am very, very proud of Finbar. And there he's got 100 people together in Belfast. That was 2018.
Can I just say, Cliff, I mean, in medicine, and learning medicine, there is still that aspect of apprenticeship, isn't there? I wouldn't, a disciple, if you like. In other words, some of these things, you can have the books and things, but it's caught as well as taught. Would you agree? Doctor
means teacher.
Right.
The word doctor means one who teaches in Latin.
Yeah.
Okay.
Yeah.
If you're a doctor, you're a teacher. You teach your patients, and you should start teaching other doctors and medical students and lay people.
Yeah.
You should start educating, because it's when you start teaching that you learn the most.
Very good. Love it. Love it.
And you know that, Andy.
Oh, well.
You've done it. And Finbar knows it. And he's having more fun than he's ever had in his life ever since he started teaching.
I would agree, yeah. That's good.
So there we are in the Europa, and I'm showing the picture of Finbar to this group of people he got together this year, just a couple of months ago, in October. The 13th of October, I think it was. So that's 2 months ago. And there we are in the most bombed hotel in Europe, the Europa. 33 times it's been bombed. No one was ever killed. And there you are, Andy, in the Europa. There you are.
Yeah.
And there's Simon Clark, who is one of my co-authors. He's a dermatopathologist. We have traveled the world together doing this sort of thing. We both have academic titles in Iran. We're both distinguished visiting professors at Tehran University of Medical Sciences. And we've presented in Ukraine, Georgia, all over Australasia. And anywhere time we get a chance, we do it together. So now you ask me, how do you get to see enough patients doing skin cancer and primary care? Any advice? So my advice is never go into shooting country or tiger country without a gun. Never go into tiger country without a gun.
Yeah.
Because if you do, you'll find a tiger for sure. Never, ever go to work without your dermatoscope with an arm's reach.
Yeah, here's my...
And I mean that. Because you need to be able to pounce on a lesion as soon as you see it. You can't go searching through the cupboard.
Absolutely, you're spot on. I take my dermoscope. We do home visits, and I picked up 2 melanomas, and just by saying I don't like the look of that. And in France, there was a study where almost 50% of melanomas were picked up just by hunting, just by someone being aware, saying, "Ooh, I don't like the look of that." So, I think for colleagues in primary care, you are always on the hunt, even if you're seeing someone for a cough or a cold. Look at their skin.
Well, if you don't take your dermatoscope on your house call and you see something that you want to put it on, you'll forget about it.
Yeah.
And a diagnostic opportunity will be missed.
Well, Cliff, I had what we call an F2 doctor who comes out for 4 months, having just done medical school in their first year. And I showed her how to use a dermoscope, and I said, carry this around with you. She went on a home visit to do a routine check and found a melanoma,
And that's amazing. That's a really good story. So you better have a photograph of that melanoma and of that girl, that doctor, because that's a good teaching.
It's one of my YouTube shorts.
Fantastic.
So on the
Fantastic.
channel, it's a YouTube
That's brilliant.
short. Yeah.
That's brilliant. Brilliant.
Yeah.
Now, you asked me if there's any other skills I'd recommend clinicians consider learning alongside dermatoscopy. So what I've said here is the science of skin cancer. You need to understand what's going on at a microscopic level under the skin in response to what you're seeing with your dermatoscope. So the evolution of skin, the history of skin cancer, the embryology of skin cancer and embryology of skin, physiology, vitamin D, melanin synthesis, albinism, did you know that albinos do not have an increased risk of melanoma? That's interesting, isn't it?
Yeah.
So it's important to know a lot about what goes on in the organ that you are treating. You're a doctor.
Yeah.
And the first thing we learn at university as doctors is anatomy.
Yeah.
Physiology.
Yeah.
Things quite apart from how to do an appendectomy.
That's a problem in the UK. I don't know about Australia, but in medical school, even postgraduate GP training, the basic understanding about skin is very rudimentary. If someone sits in with me, first thing I do is give them a piece of paper and say, can you just draw a cross section of the skin? Because if you don't know what a melanoma is, where it sits, if you don't know what the basal cell does, if you don't know what the keratinocytes are doing, then you're not going to understand what you see under a dermoscope, are you?
So, Andy, did you know that BCCs don't come from basal cells?
I remember you saying that. Enlighten me again.
Yeah, they don't come from basal cells. They come from the stem cells of the hair follicles.
Right.
And the reason we know that is that you do not get BCCs where there are no hair follicles. You don't get them on the palms of your hands, the soles of your feet, the vermilion lip, the glans penis, the labia minora, the nail matrix, the nail bed. You do not get them where there are no hair follicles. So BCCs are basal cell carcinomas. They do not derive from basal cells.
Right. Interesting. So should we rename?
I just threw that in. This is the sort of stuff that you need to know. It's all in the book. It's all in the book.
Should we call them hairomas then, or folliculomas?
No, you call them basal cell carcinomas because they differentiate to look like basal cells.
Fine. Okay.
And we don't want to make it too easy to know what's going on. We have to need to buy a book to learn all this stuff. And that makes it more interesting because that's just one thing I'll point out to you. There's lots and lots and lots of things like that are misconceptions.
No, I think I like about your book, Cliff, is that it's very GP orientated. In other words, you don't go into a lot of the esoteric, rare stuff. Because when you're starting out, if someone tells you 10 different things, you don't know what's really, really important. And I like how you concentrate on the important things that you need to learn first. You can always go into the rare things later, can't you? But you have to understand the basics first.
Absolutely. Right. And it's the basics that you won't get from Google. You get the esoteric things from Google, but you won't get the basics. You won't get those.
Absolutely.
Now, about cryotherapy, the most important thing is to know when not to use it. Don't freeze an amelanotic melanoma. Only freeze a lesion, which is a solar keratosis with hard keratin scale on top. Don't freeze it if it hasn't got it, because you might be freezing an amelanotic melanoma.
Good thinking,
Now, anything else you say to a young clinician just starting on the journey into dermatoscopy? Well, get a dermatoscope with both polarized and non-polarized options and use it to deliberately look at common, banal, benign things. That's the first thing you got to do. Become an expert at what is benign. And then you recognize what is not benign.
Excellent.
Now, you made this comment that primary care is the master of benign. Secondary care is the master of the malignant. So I just rearranged that, and I say primary care is the master of general diagnostics and therapeutics. Secondary care is the master of advanced diagnostics and therapeutics, both limited to a very narrow field. So the secondary care person has a much more focused expertise, whereas the GP has a wider expertise. But in Australia, most skin malignancies are detected and treated in primary care.
Do you know, I'm very envious of you because, I mean, it's in the wrong sort of way, because you have so many melanomas where you are in the UK. I will probably, I do a fair amount. I probably see 2 melanomas a year, and so getting that experience, and we're not allowed to cut them out. My secondary care colleagues, I might go. I cut out a couple last year which were atypical, and they ended up to be melanomas. With a good excision margin and all that, and I referred them on, and I got very snotty letters back.
Well,
I'm trying to save my patient and then trouble.
Well, there are opportunities for doctors to come to Australia.
All right, careful.
Ask Finn Bay. He came here for a year.
Enough of that.
Now, what are the most common beginner mistakes I see? Okay,
Yeah.
well, failure to recognise the obvious. So this is a young woman. She was 30.
Mm.
A month before I took these photos, she had a well woman check in London prior to her immigration to Australia.
Mm.
This was overlooked.
Mm.
There was no comment or any concern about this in her well woman check. And this was, excuse me, this was an invasive melanoma with a basal thickness of 2.3 millimeters. She's 30. Wow. It's metastasized. She's still okay. This is over 10 years ago. She's still okay. But this is a totally unnecessary misdiagnosis or delayed diagnosis. Yeah. With something which should have been obvious even at just a close-up look.
But I've seen seborrheic keratoses look like that. However, as soon as you put the dermoscope on, it's a different picture, isn't it?
And I'd say that's what has gone through the person's mind. They haven't had the dermatoscope. This just shows it's absolutely essential to have a dermatoscope. So when you see something like that, you can sort it out in a second.
You can.
If it's a SEB-K, a second.
Yeah.
Okay. Yeah. So this is the one thing. If anyone's watching this and hasn't got the dermatoscope, and they see patients with a bellyache, right? And they see something like this, they need to have a dermatoscope in their bag to look at that. And I guarantee every person that's watching this would recognise that as something abnormal.
But Cliff, in general practice, certainly in the UK, we are busy. You know what I mean? And if your mind's not on it, it's easy to overlook those things unless you're kind of like trained to stop.
That's why I'm showing you these photos.
Okay, all right, thank you.
That's why I'm showing you these photos.
Yeah.
Now, you'll only miss that if you don't look inside the mouth. When I do a skin examination, that's the first place I look. Well, the patient's sitting in front of me on the couch, I look inside their mouth. And I'll show you in a minute a link to me doing a skin check. But this is a nasty melanoma. That's the same melanoma.
Oh.
Now, you wonder how someone could miss that. This guy's been having his blood pressure checked every 6 months for 16 years, while this thing has enlarged in size.
Mm-hmm.
Okay, I can understand it being missed back here, but this should have raised eyebrows, and then this. That's crazy, That's an invasive melanoma. It would have been in situ probably all the way, most of that 16 years. So we need to, and obviously the doctor that's checking the blood pressure every 6 months, it's not changing from 6 months to 6 months.
No.
It's just getting ridiculously big. And this shows that a melanoma, which is not stopped, will eventually get ridiculously big. Melanomas never stop growing. And, you'd wonder how it got to that size, wouldn't you?
Yeah. I mean, the first one is like a lentigo, isn't it? It's a simple lentigo.
Sure. But it would have been a melanoma. That would have been a melanoma.
Yeah.
It's not changing from a cat to a dog. It's changing from a puppy to a big dog.
Right. Okay.
Fair enough. And so this is whenever you get a melanoma on the face, you can go back and ask them for selfies. And you can see this every single time. It's not changing from a pussy cat to a tiger. It's changing from a tiger cub to a grown tiger. Yeah. And this is something which is relevant to the myth about melanoma precursors. It's a myth.
Right.
So we don't routinely look at the genitalia, but we certainly ask about the genitalia.
Right.
because he wasn't worried about this
All
until
right.
he was asked.
Really?
He just thought it was, you know,
Do you know
one of
what?
those things.
It is so amazing how patients get used to stuff. So I had a guy, he had 6 BCCs on his trunk. And I have a little question I asked, and anything else, and anything else. And then he rolled up his left trouser leg and he had a 2-inch nodular BCC fungating and weeping. And I said, how long have you had that? And he said, oh, 9 years. You know, and seriously, it's
Well, he's
true.
lucky it was BCC, wasn't he?
Some patients, you think, what are you doing? I mean, you know, if that was on my, you know, Jimmy Dodger, you know, you think, what's going on?
Yeah. Anyway, it's so they're both nail matrix melanomas,
Right.
but the one on the right, a GP's been keeping an eye on that for 3 years. So that hasn't been biopsied yet. That's the photograph that the patient sent in, but it's obviously a very advanced nail matrix melanoma. Now, this is interesting. So this lady presented for skin check. She wasn't worried about this because she'd been having skin checks every year, and that had been there, increasing its size for 3 years. Look at the shape, Andy. Look at the shape. There's a paper, geometric cutaneous melanoma, right? This has one picture in it. This is from 2003. It's square. Look at that.
Yeah.
Square. Yeah. That's an invasive melanoma. As I said, they keep getting bigger and bigger and bigger. There's another one from 2 months ago. This one I cut out just before I went to Belfast. I didn't have the results when I left for Belfast. I cut it out. The results came through. It was a melanoma in situ. Look at that straight line. Look at the square angles.
Yeah.
Look, this is one from 2 weeks ago. Just 2 weeks ago. Another melanoma in situ. Yeah. How about that? Triangle.
Yeah.
How about the love heart? Look at that. Isn't that beautiful? These sharp angles, straight lines, and there's a heap of them.
There's a heap of them. So when you talk about the shape, is this something that, you know, you're used to the normal rounds, and as soon as you see something geometric like that, you should suddenly think, maybe?
Well, here's the map of Australia, second from the right on the bottom.
Yeah.
This one you might call a shark or a helicopter.
Yeah.
But you got the triangles. You've got a beautiful triangle here. This is a shark with a nose. Now look at this one here. This is inside the lesion, inside the melanoma. A geometric shape. I have no idea what that correlates with. And I have no idea what causes the squares and the rectangles. But if you see them and they're not a SEB-K, they're a melanoma. Now here's a SEB-K.
Right. Yes.
You'll see this with SEB-K, but the dermatoscope sorts that out in a second.
It does. Yes.
And also when you run your finger over it, you'll feel it raised.
Yeah.
Whereas the melanomas, they're flat.
Okay.
When a melanoma gets palpably raised, it's already got a Breslow exceeding 1 millimeter.
That's a good tip.
So if you haven't got your dermatoscope and you want to check if something's a SEB-K, run your finger over it. And if you can't feel it, then you better go find your dermatoscope.
Right. Yeah. Yeah. I mean, would you agree, you know, in terms of nevi and things, sometimes you get something that looks a little bit odd and you monitor it for 3 to 6 months. But a general rule I was taught was that if it's raised, you don't monitor for that reason.
You certainly don't monitor because if it's a melanoma, it's already invasive and it's already thick invasive.
So you don't monitor raised lesions?
No, you don't monitor clod pattern lesions because clod pattern melanomas grow faster.
Okay.
Now, one concept you wish every GP knew before seeing their first lesion, well, never forget that the most dangerous melanomas don't look like melanomas.
Right.
They're all melanomas.
Right.
They're all melanomas with bad outcomes.
Yeah.
The one on the bottom right killed the patient.
Yeah.
Only had a Breslow of 1.5. So it didn't look like a melanoma. This one on the ear, that came after a magpie pecked him on the ear. Wasn't there before. Nodular melanoma, 3 centimeters in diameter, 1 centimeter Breslow, 10 millimeters Breslow.
Yeah.
This is a melanoma of the nail matrix. This is a melanoma of the nail matrix. This is a melanoma of the nail matrix. This is an acral melanoma on the sole of the foot.
So Cliff, you're worrying me here. You know, do you know what I mean? So when you first start off, these are the things that worry you. And a phrase I have is, in one sense, it's a high index of suspicion, isn't it? So if I don't know what it is, I should be concerned. And I usually say, if in doubt, refer it out. Would that be reasonable?
If in doubt, cut it out.
Okay.
If in doubt, don't refer it out. Do a biopsy.
Well,
Now, for example, this foot up here, right? You can see the foot on the left-hand side.
Yeah.
This has been managed for 3 years by GP for infection. He had ultrasounds which were normal. Ultrasounds were normal. Okay.
Wow,
So we looked at it and we said, well, this is a non-pigmented lesion that's ulcerated.
Yeah.
That's it.
Yeah.
Right.
Yeah.
And 3 years, you don't get diabetic ulcers under the foot. You get them on the leg.
Yeah.
And this patient wasn't diabetic.
Yeah.
So we did an incisional biopsy from normal at the top, straight through there, 2 millimeters wide.
Wow.
Right?
Yeah.
One big stitch to hold it together, and sent that off and got a diagnosis. A melanoma with Breslow thickness of 8 millimeters.
Wow. So I guess the other thing from that is then, if it's not responding as you would expect, revisit your diagnosis.
Absolutely.
No.
And any ulcerated lesion that's not healing, you must consider melanoma.
Okay. Good thinking. Yeah. That's good.
This one here on the bottom left, right?
Yeah.
This one here, the doctor had been at one of my presentations, just like Finbar had.
Yeah.
And he heard me make the comment, only the pathologist can see melanocytes.
Right. Yeah.
I was saying you can't decide whether something's melanocytic or not if it's not obvious, like if it's not a BCC or not an EVIS. You can't decide without the pathologist seeing the melanocytes. And when I said only the pathologist can see melanocytes, he thought of this patient, didn't sleep the rest of the weekend. They've been treating this for 2 years as an infection, antifungals, all sorts of stuff, and did a biopsy and it was all melanoma.
Wow.
All melanoma. So I'm showing you this because people that are watching this, in a lot of cases, wouldn't have thought melanoma for any of these.
Yeah, and I think when you're starting off, when you're feeling uncomfortable as you go through that learning curve, as you learn your basic benigns, there is nothing wrong in over-referring initially. Yeah, particularly for things that are really something's going on odd.
But there's nothing wrong with doing a biopsy. I know you're not supposed to cut out a melanoma, but if you see an ulcer, can they stop you doing a biopsy?
No, they can't.
If you see an ulcer. Now, don't do a punch. A punch will be a waste of time. Do an incisional biopsy. Take a sliver of skin, 2 millimeters wide, from normal skin on one side, from normal skin on the other side.
You know, there are some
stitch.
There are some
and you put the stitches in the normal skin. Put the normal stitches in the normal skin. Don't put them in the mucky stuff. It'll pull through.
No. I mean, there are some GPs who might be watching from around the world who are very isolated. They don't have access to that. And so, to say to them, look, get a biopsy for something like this,
Absolutely.
Okay.
A biopsy is much quicker than a referral.
No.
And they won't poo-hoo you for biopsy, something like that, if it comes out an invasive melanoma, and they won't really care if it's not, if it turns out to be a benign ulcer, but make sure you do a good biopsy. Otherwise it's a waste of time. Do an incisional biopsy and make sure they section it longitudinally, not transversely.
Okay.
So you're right on the form, incisional biopsy, block hole, WHOLE, longitudinal section. So they cut it the length of the incision, not across the incision.
So foot on the left, sure, it's a common area for foot ulcers if there's extra pressure due to the foot arch collapsing, but it's clear callus around it, and if it's ulcerated, it is caved in. Yeah. I think for me, that foot ulcer one is.
So that was a question from one of the delegates?
Yeah, it was, yeah.
Yeah, no, it's a good question. Yeah. And what you're saying is you can get a trophic ulcer there, but if a trophic ulcer is not healing, you do no harm by taking a biopsy.
Right. Okay.
And in this case, you do a lot of good because you find you get a diagnosis.
It's just if it's not doing what it should do, which is heal.
Well, even if you think it's not healing because it's a trophic ulcer, there's nothing wrong with biopsying, and it's really important to do it. This is after 3 years.
Right. No, I agree. Yeah.
3 years.
Yeah.
Good question. Thank you for the question. I like questions.
Yeah.
One thing we used to teach we should retire, which is the notion of melanoma precursors.
Right.
This is a paper that Simon Clark and myself published this year, and you should read it. I would advise everybody to read this if they want to know about dysplastic nevi. That's the link.
Okay, very good.
It's an open access paper.
Excellent.
If you take a photo of that, scan that link, then you can get that paper. There are only 3 melanocytic lesions. Benign, that's nevus. Malignant, that's melanoma. And indeterminate. That's when the pathologist can't tell the difference, and they should report it as indeterminate. And they can say indeterminate favour melanoma or indeterminate favour nevus, but they shouldn't pretend it's some in-between thing, a dysplastic nevus, which is a precursor, just about to become a melanoma. Does not exist.
No.
Benign, malignant, indeterminate.
There's a good comment here. Thank you for Simon for that. I think every country is going to have their own way of approaching things, aren't they?
Absolutely.
Their own pathways and their own opportunities. I must say I'm quite jealous of Australia. I must feel like emigrating, particularly since it's 8 degrees here. And how warm is it?
Come for a holiday. Come for a holiday.
You're very tempting.
Check it out. Like Finbar did.
Yeah.
And
absolutely.
then go back and do what you're doing.
Yeah.
Now, how does dermatoscopy help your income and practice? Well, Australia is different to England. In Australia, dermatoscopy brings success to the hunt, so the hunter can feed his children.
Yeah.
If we find cancers, we treat them, and for treating them, we get paid.
Right.
Now, in England, it's different. But I used to hunt wild boar and not get paid a cent, and I loved it.
Right.
And I used to go spearfishing and not get paid for it, and I loved it.
Yeah.
So even if you're not getting paid, it's got to start somewhere.
Yeah.
And if you're finding this sort of stuff, you're teaching it. So I know it's a different scenario here to England.
It is. Yeah.
But as far as I'm concerned, that's my job.
Yeah.
I'm a hunter.
Yeah.
And I like hunting, and I actually get paid for it.
Yeah. And there is a thrill in the chase, and patients are incredibly grateful. And what I didn't realize that even patients come in worried they've got cancer and they're going to die. I've had people, not sleeping for a week. That you come in, you look at it, and you say, "Oh, don't worry, it's a seborrheic keratosis," and you see their shoulders. So it's not just finding the cancers; it's reassuring people that they're going to live.
Absolutely. Now, you've asked me if some countries do better than others. Well, the bottom line is that in all countries, the motivated clinicians perform well, largely due to the impact of the International Dermoscopy Society. So it doesn't, we get a lot of opportunities in Australasia, but in countries where melanomas are not so common, like in Turkey, for example, Nisa Akay has published the smallest melanoma in the world.
Wow.
From a place where they're not all that prevalent. So, it doesn't matter what country you're in.
Right.
It matters your enthusiasm and your application and your eagerness to learn and to make a difference.
Yeah.
And people in every country, if you go to the International Dermoscopy Society, join the Facebook group there. There's 25,000 or 30,000 members. They put up cases every day. It's fantastic.
Yeah.
And a lot of them don't get paid for treating skin cancer.
Do you know, what I find, Cliff, I was very fortunate when I started dermoscopy. I had a GP who was a little older, who'd also got a dermoscope, and having a local colleague you can chat with, just to encourage one another and just say, "Oh, have you seen anything this week?" And you share your experiences, don't you?
Absolutely. Now, a 10-minute consult. What's a good dermatoscopy practice look like in a 10-minute consult? Well, I don't know about 10-minute consults. I don't have too many of those. But a good dermatoscopy practice means having a dermatoscope with you in the consulting room at all times. That's what it looks like. And if you have it, you'll use it. Because it's important as your stethoscope in general practice as a dermatoscope.
Yeah.
20% of GP consults are to do with the skin, or 16%.
Yeah.
And it's really, really important to use it. Yeah. And if a patient points something out to you, have a good look at it with your dermatoscope. Don't just look at it.
Yeah.
Look at it with your dermatoscope.
Cliff, we've got a really good question here, but dermoscopy among GPs is a rarity. I presume that's in the UK and many parts, but normally just biopsy them instead. I mean, I don't know about you, but my thought is the idea of dermoscopy is you reduce the number of biopsies. So, you know, I remember some of the early studies said that it used to be 18-1 without a dermoscope. And then with the dermoscope, oh, Finland, thank you, is that you reduce it to 4-1. Is that right?
Yeah, look, before dermatoscopy, 100-1, 50-1, depends what country you're in, right?
Yeah.
With dermatoscopy, look, the experts on SCAR got it down to about 4-1.
Wow. Yeah.
So 4 things or 3 things biopsied for the intention of excluding melanoma to get each melanoma.
Yeah.
And experts 1.6, 2 for every 2 things I test. One's a melanoma.
Yeah.
And dermatoscopy,
Mm.
it saves the lives of many benign, innocent lesions.
Yeah.
Okay.
Yeah.
And it's also saves the patient the cost, the pain, the needles.
Yeah.
The pathology, everything you cut out. There's a pathology bill that goes on top of it. There's a lot of cost to skin lesion assessment.
And in general,
and when you say GPs, it's rare in general practice. Well, it shouldn't be, and that's the purpose of what I'm doing here, what Andy's doing, what Finbar's doing. Dermatoscopy should be a step between a lesion and an excision.
Yeah.
It should not proceed from lesion to excision without a dermoscopic analysis.
Although sometimes, you know, the thing about this is in each country, if you do a biopsy, you might get paid. If you do dermoscopy, you don't. So it's incentives as well sometimes. And your point about dermoscopes, I mean, this was what, £1,500? I mean, they're hugely expensive. But now, which is one on the channel, I'm looking for dermoscopes that work and are very cheap. And now some of the Ibulu dermoscopes for like £250, they do polarized, non-polarized, ultraviolet. They are getting cheaper and more accessible. That's the great thing, isn't it?
That's great. That's great. Yeah. Okay. Photographs. Yeah. Look, photographs. You can see the benefit of having photographs. They're great for publication. But I go back and look at photographs I took 15 years ago, and I still learn from that.
Mm.
As recently as in the last couple of weeks, going back and wondering, what made this a melanoma, and you've got the photographs. They're invaluable. And also, if you want to get some advice from Andy or from Finbar, you can send them a photograph. It's the everything that you cut out. I recommend taking polarized and non-polarized, close up and a context shot. Yeah. The most memorable thing that I've seen that completely changed how I teach. Now, this guy came to me in 2006.
Yeah.
Back then, we didn't use a dermatoscope for non-pigmented lesions. So what do you think that is, Andy?
It could be almost anything. It could be an insect bite, dermatofibroma.
Okay, it's a dermal nevus.
It's a dermal nevus, right? I mean,
what do you think that is?
Yeah, it could be anything. It could
be a squamous cell carcinoma in situ.
Right.
Okay, what do you think that is?
Well, again, there's a whole long list. You know, it could be a Bowen.
Melanoma invasive, Breslow 0.8 of a millimetre.
Right.
So without a dermatoscope, that's where you are, flying by. Right. And now we do use a dermatoscope for non-pigmented things, and we can recognise melanomas by their vascular pattern. Mm. It just made such a huge difference, and now we've got an algorithm. Mm. Now, by the way, I don't know of any other algorithm for non-pigmented lesions apart from prediction without pigment. So if anyone knows one, let me know. Mm. But it's fairly unique, and it's very, very, very effective.
Yep. Yeah.
Now, has dermatoscopy ever changed a patient's life in a way that stayed with me? This was a 25-year-old school teacher. Yeah. He had this for 6 months, stripe on his nail.
Yeah.
That was the dermatoscopy.
Yeah.
Lines parallel, chaotic. Lines parallel, varying in width, interval, and colour. One of his students, 13-year-old girl, told him that he had a melanoma on his thumb. So he ignored her. Mm. 3 months later, she asked if he'd been to the doctor with his melanoma. He said no, so she rang his mother. So she's the silent author on that paper, because 2 weeks after that one, another one walked in, a friend of his with a melanoma on a toenail.
Yeah.
I will make the point
that
you don't have to have lines parallel chaotic. Any longitudinal melanonychia, that's a pigment stripe, chaotic or not, arising at a single nail after puberty with progressive widening requires a biopsy.
Yeah, yeah.
Now, this particular case is written up and published. The 13-year-old is my daughter, my youngest daughter, and she didn't tell me at the time. She explained that as student-teacher confidentiality.
Wow.
I found out after the patient was referred to me from the melanoma unit that she had been the student. There she is on the right-hand side, graduating from UQ. She's just finishing her 10th year at the University of Queensland. She's got 2 more to go, doing an intercalated MD PhD.
Yep.
So that's actually where you can, if you want to take that, you can read the story. It's published about that particular school teacher and the student. Now, that's what they look like if you don't diagnose them at the in situ stage. So on the right-hand side of the teacher, he's fine. That was many years ago.
Yeah.
On the left-hand side is the example of one that's had a fatal outcome that wasn't diagnosed.
Yeah.
That's a QR code to a video of a nail matrix biopsy by me.
Yeah.
So anyone wants to see how it's done, I'm sure that if you don't get the picture now, that Andy will share that with you if you want it.
It's there, yeah.
Now, quick fire quiz. You read them, I'll give you the response.
Polarized or non-polarized?
Both.
Okay. Contact plate or non-contact plate?
Both.
Okay. Blue-white veil, overused or essential?
Veils are for weddings. We don't use metaphoric terminology.
Okay.
We just talk about blue and white.
Okay. Favorite algorithm?
Yes, cast includes a prediction without pigment.
Okay, for general practice. If a GP's master of one lesion first, which should it be?
Master each of the 5 common benign categories simultaneously.
Most underrated clue?
Always look for blue or grey and an eccentric structureless area. If the others are there, you will see them.
Right. Starburst pattern in a child, panic or patience?
Neither.
Right.
If it's nodular, excise it. So it's spitz nevus. If it's flat and black, a reed. Tell the parents that it's got a 1 in a million chance of being a melanoma.
Right.
And they'll get you to cut it out for sure.
Right.
Let them make the decision.
Yep. Good. Yep. Like it. Excellent.
Now, you can read the questions. I'll answer them.
Yeah. So where do you see dermatoscopy education heading in the next 5 to 10 years? What do you think?
Well, it'll be much of the same.
Right.
AI will become useful as a second opinion, which you can get 24 hours a day from a machine that doesn't get hungry and doesn't sleep.
Yeah.
But it will make mistakes.
I've had comments from people on my channel saying, "Oh, forget all this stuff with dermoscopes. You know, AI is going to be taking over." So you think there's still a role for us?
Good luck. Not in the next 10 years.
Right. Okay. Right. Yeah. Okay.
So that means for all of us watching now, keep learning dermatoscopy. You'll still be able to have some fun.
Okay.
It's not going to take the fun out of it just yet.
It's a good partner. Yeah. Okay. Yeah, absolutely. So that's how I feel about it. Yeah. Very good.
So it's a partner. AI is a partner. It's not going to replace. And as far as if AI becomes good at spot diagnosis, well, someone has to feed the spot to the AI. The AI can't find the spots. So if you've got a patient with 1,000 spots, you've got to decide which ones the AI looks at.
Okay.
Now, this is a question you asked me, Andy.
Yeah.
So why did I write the book? Well, I figured that it was important to have a manual when you're a hunter. This is one of my favorite authors, Jim Corbett, Man-Eaters of Kumaon.
Yeah.
He'd only hunt a tiger if it had killed 100 people.
Yeah.
And when I was teaching in the Master of Medicine course at the University of Queensland, I put together a reference book for the syllabus.
Yeah.
And it was mainly reference material from other people, all put together and referenced.
Yeah.
And so it wasn't a big step to go from that to writing my own book.
Yeah.
Under the same headings.
Yeah.
but with my own content.
Right.
Still a very reference book. You'll find lots and lots of references in my book because other people have gone before me and given me lots of useful things to build on.
It's like that old saying, isn't it? We stand on the shoulder of giants, Cliff. You know, I mean, I've loved reading your book. Can I just comment on your book? You know, because
Certainly, absolutely.
I mean, you know, I've read quite a lot of dermoscopy books, and I like looking at them. And what I really love, the pictures are awesome. It's glossy, and you can really, you know, see what you're talking about. And I think because sometimes there are things that you see rarely, to have something already in the mind to say, that's a white circle looks like, because you see lots of sort of white circles, don't you? But that's a white circle, you know. So I love the pictures because half of it is good pictures. Also, the text complements it, but it doesn't overcomplicate it in that, you know, you don't focus on all the rare things. You really do, you know, point out for the GP, look, these are the, you know, things you should be looking at. Yeah.
Oh, thanks, Eddie. That's a nice little summation of it. Now, you asked me about my co-authors. Here they are.
Okay.
So I wrote the text. I gave Oksana, with the first edition, 100,000 images to sort through to find the best 500 for the book. And she did. She sorted through 100,000 images.
Whoa.
Mohammed Hassani, he's a genius.
Yeah.
He published a UQ flap. That's a modification of the keystone flap for excisions below the knee where it's very, very tight.
Yeah, yeah.
Greatly increased the size of defects that can be closed without a skin graft. It's taking off. He got the best. We got the best publication or the best reconstruction of flap of the year. I think it was 2022 or 2023.
Yeah, yeah.
In New Zealand, it's a big thing. The QR flap was a QR flap. I was at a recent conference over there where it's presented. Simon Clark is a world-renowned dermatopathologist. We've travelled extensively together and we've published dozens of papers together.
Yeah.
And I keep arguing about things like what causes polynization-specific white lines. He thinks it's epidermal. I think it's dermal. And we're still trying to sort that out. And it's fantastic having people that you can grapple with things like this.
Yeah, absolutely.
These people have all contributed to the total final book. Ideas, intellectual input. Oksana did all the original graphics of the first book and the collages. Mohammed's redone all the graphics and he's done the new collages. Right. And Simon's written the dermatopathology chapter. So it's a teamwork. It's all teamwork. There was nothing hard. It was just really all good work. And
thanks for writing it, because looking at the other books, I mean, I've got, for me, it's a good, really good starter book.
Yeah, and who's going to benefit? Well, those who want to enjoy and excel in dermatoscopy. And enjoy is the big thing. I think. I hope my book gives you a lead in how to really enjoy your work, because that's my main aim in educating, is to help doctors enjoy where they spend most of their life, and that's at work.
Yeah.
A happy outcome, very happy with the outcome. And what bits in particular you're pleased with? Well, the whole thing, and starting with the cover, and I'll tell you about the cover in a minute. Right? It's an interesting cover.
Yeah.
Here's the first edition and the updated edition. They've been translated into Polish, Ukrainian, and Farsi.
Wow.
And they're the names of the translators underneath there.
Yeah.
This is the new edition. You can see it's much fatter than the previous one. You can see on the right-hand side, it's much fatter. It's more content, more pages. Yeah. And it's being currently translated into Lithuanian and Norwegian by Asta.
Yeah, yeah. I think we need a Finnish. A Finnish one,
Well, I'm happy for a Finn to translate my book. I'm happy for anyone to translate my book.
Fair enough.
I think it's got a reasonable rendition in English. I think we did pretty well with English.
Yeah.
But now you asked me what surprised me most when updating the second edition. Well, it made me think about things, and this is an example. So when we published the first edition, when we laid the patient on their side, we put the top leg back and the bottom leg forward. Now we put the top leg forward and the bottom leg back, because some people can't lie face down. If they're pregnant, they can't lie face down. If they're obese, if they're old. If you put the top leg forward in the recovery position and lean the patient forward, you can examine the whole posterior surface of the body without making the patient lie down. So you do it in the right lateral and the left lateral,
Right.
and face up, and you can do the whole thing. So that's one difference, and that was come about by thinking about the second edition. What can I improve in the examination? Now, that's a QR code me doing a skin examination.
Yeah.
To me, so you might want to share that later.
Yeah, it's on here. People can screenshot it. Go from there. That's great. Yeah.
And ideas. Now, this is an idea of Muhammad's, the third co-author, about the dermoepidermal zone, a crucial shaper for dermoscopic structure. So you can see here, the dermoepidermal zone contains both the dermis and the dermal papillae and the radial ridges. Right, the epidermis and the radial ridges. So epidermis and dermis. Then you've got the supra DZ epidermis and the sub DZ dermis. And this is a really useful way of considering the skin. If you've got pigmentation in the radial ridges, you get network. If you have pigmentation in the dermal papillae, you get clot pattern nevus.
Yeah, that's a good way.
Okay. So this is something in the second edition, which wasn't in the first edition, and this is from Muhammad, as I said, a genius, and he's actually working on a new book called Dermoscopy, histology, which is using information from dermatoscopy and confocal microscopy to understand histology.
Yeah. I like to describe dermoscopy, the decoding of histology without resorting to a knife.
Well, the dermatoscope is a microscope.
Yeah.
It's a microscope with 10 times magnification, and it sees the whole surface of the skin, not just less than 2%, which a microscope does. It sees the whole surface of skin to a depth of 1 millimeter. Now, all the action which determines whether something's a melanoma happens in the first 1/10 of a millimeter of skin.
Right.
And the dermatoscope sees all of that at 10 times or 20 if you're using a photo finder.
Yeah.
And that's really, really significant because it means someone like Simon Clark, when he makes his histology report, the first thing he does is hold the slide up to the light without any magnification at all. To have a look for the silhouette and the architecture. Then he puts it under the microscope at 12 times magnification, and that's when he makes his diagnosis. He only uses the higher powers for finer detail. So
that's a really useful picture. That's a really useful picture. Can I use that picture?
The dermatoscope is a microscope.
Yeah.
It's a low power microscope which shows you the whole lesion.
Yeah.
So
that diagram's in the book, isn't it? So
this diagram's in the book.
Yeah.
It's in the second edition, not the first edition. So if you've got the first edition, you need to buy the second edition to get this diagram. Now, you asked me, is there a Rosendahl rule? No, there's not. Everything I've done is teamwork. I don't want to be remembered as a sign. You can remember me as a spear fisherman if you want to, but not as a dermatoscopic sign.
Yeah, okay.
Because there are plenty of people that have discovered a lot more than I have. How does it's different to other books? Well, it goes into the microanatomy, the physics, you know, what gives you black color, what gives you brown color, what gives you gray, what gives you blue, what gives you pigmented circles. You can see in this here, the melanoma going down the hair follicles. Here's the pigmented circles, and here's the lesion. This is the sort of book it is. Correlations, everything.
Yeah.
And why should our audience consider buying it? Well, it's a 0 to hero book. 0 to hero. And if you should start with chapter 1. Okay. Every part of it's important, and it's all in the right order.
Yeah.
Now, just a couple of things here I'll mention. There's a new section on melanomas with adverse outcomes. This one killed the patient. This is a melanoma, a tiny melanoma. Breslow 0.5, it metastasized. The patient's doing fine on checkpoint inhibitors. This is a melanoma, only a 0.9 Breslow, it's metastasized to the brain. And this is a melanoma which has metastasized, but the patient's doing fine on checkpoint inhibitors. Yeah. The section on nevi is particularly good. A section on dysplastic nevus. This here is a congenital clot pattern nevus with a melanoma arising from it. This is the most common nevus associated with a melanoma.
Right.
dermal nevus.
Right. Wow. Do you know, I've got it wrong. I've got it wrong. Now, I see patients with dermal nevi, and I know the odds of it turning or getting a melanoma is very low. You know, I'm going to change what I say now, because I see someone with a wobble positive pink dermal nevus or whatever, and I say, oh, don't worry, it will never turn into melanoma.
No, and it will never turn to melanoma, but a melanoma may arise from it.
Okay.
No nevi turns into melanoma. Melanomas arise from nevi.
Sure.
And dermal nevi are the most common nevi, and that's why melanomas commonly.
Okay. Yeah.
And there are many dermal nevi you don't ever see.
No.
They're under the skin. Most dermal nevi are not visible, and the ones that are associated with melanomas are not visible usually.
Wow.
Clinically.
Wow.
They're found by the pathologist.
Wow. Okay.
Now, this is the section, a brand new section, photographic technology.
Oh.
This shows a completely symmetrical invasive melanoma, and it's detected by reference to images, total body photography images taken a year earlier. Look how much it's increased in size in 1 year.
Yeah. No.
Dermoscopically, okay, it's symmetrical, but it's got the exception of a changing lesion on an adult.
Yeah.
Because even without these pictures, it's got peripheral clods. That means it's changing.
Yes, I do.
Enough to cut it out.
You know, yeah, that's right. Because when you're younger, they're growing that nevi, and you get the peripheral clods. That's normal. But as you get older, you shouldn't be getting a new nevi, should you?
She's in her 50s, and when you see a growing lesion like this in the 50s, it's not a SEB-K.
Yeah,
it's a melanoma. It won't be a nevus.
No,
not in the 50s.
Yeah.
Now, what else do I get up to? Well, I like English cars.
Okay.
And Stephen Hayes, I don't know if he's here tonight or he's going to watch this later, but he had to come to Australia, get picked up by me from the airport in my Rolls Royce. That was his first drive in a Rolls Royce.
Right.
And I felt pretty good about that.
Have you still got that car?
I certainly have. I've had it for over 20 years.
Have you really? Wow.
It's a really nice car. It still drives like a new car.
Is it really?
And I will never get rid of it.
Well, you get no rain in Australia. You don't need the salt on the roads to destroy it, do you?
Well, we don't use salt on the roads, but I live right next to the sea. But the beauty about a Rolls Royce, it's made of aluminium.
Right.
Did you know that? It's made of aluminium.
Right. Okay.
Doesn't rust.
Right. Yeah.
Now, here's my other English car. This is a Jaguar 3.8S, and that's my kids in front of it.
Mm-hmm.
This is 30 years later. That bloke on the left is that little fellow in the middle there, right?
Yeah.
And that's his kids, same car.
Wow.
30 years later.
Amazing. Yeah.
And that's where I am right now. And that's what I would see if I open my window and look out.
I'm not going to be too jealous.
Yeah, see, that's a coconut tree. I've got lots of coconut trees.
Yeah.
And that's the timber that I turn into pizzas.
Yeah.
I chop wood and I put them in my pizza oven.
Yeah.
And turn them into pizzas.
Wow.
And that's on the left, me with my son, who's an archaeologist, and we're eating pizza. And on the right, you see with Stephen Hayes and my wife and my youngest daughter, and we're drinking coconut milk out of the coconuts we just harvested.
You're painting a very tempting picture, Cliff.
Well, my wife is a hunter.
Okay.
Right? And that's the hunting theme. And now I'll tell you about the book.
Mm-hmm.
That's a tattoo on a lady's thigh. And you can see right between the wolf head is a black mark.
Wow.
And there you can see the dermatoscopy. It's chaotic. It's got a clue of white lines, right? And I wanted to put the crosshairs of the sniper's rifle on the cover of the book. The publisher wouldn't let me because they said it looks like they're shooting a dog.
Yes.
That's what it looked like when my colleague cut it out, right? We managed to save the wolf's eyes, which is very important. And that's how it is in the book. And on the right-hand side, what's the explanation of the inside cover of the book.
Yeah.
And I reckon that's a great, great cover for a book.
Yeah.
Every part of this book is good, starting with the cover.
Yeah.
Thank you very much.
No, hey, Cliff, I really appreciate your time and everyone joining in. If you've got any final questions, now's the time to type them. You know, having listened to that, we got Cliff here. It's a great chance to, ask any final questions. I mean, what's the rest? It's the evening there now, isn't it? So,
it's dark
what's in store for you for the next few weeks? Because I know you're a globetrotter. Is it time at home or what you doing?
No, I'm at home from now until April when I'll be heading over to Europe again.
Lovely.
So
Excellent.
there's plenty going on here in Australia. So it's
Yeah.
and this has been a great way to see out the presenting side of things for this year. This is my last presentation for the year.
Right. Okay.
So
I mean,
far.
yeah, really, really. Hey, Cliff, your wisdom, your knowledge there, brilliant. We might, pick up on a few things another time. Folks, this,
Hang on. I just
as we end the stream, it's going to be, you can go back and watch any of these things. We've put a few little clips in there. I'll make sure all the links are there for the, predicting without pigment and all that sort of thing. And also the 35% discount for the book. Any final words, Cliff?
No. Thank you very much. I really enjoyed this, and greetings and best season's wishes for everyone that's out there listening. I hope you all have a very safe holiday season. Is it holiday season over there? It certainly is here.
Yeah.
In the Northern Hemisphere, do you have holidays at this time of the year?
Yeah, no, it's been great. I really appreciate it, Cliff, and the effort you've put in, because I know you put a lot of effort into the presentation and just answering the questions, and I hope it's what people have wanted. Yeah, I mean, it's amazing, isn't it, what we can do for teaching now? You talk about us being doctors and teachers. Now you can teach globally, and also this is there. People can dip back into it and watch it again and all that. I mean, I think it's wonderful.
I really admire what you're doing, Andy, and Finbar too. And I know to get the word out there and make it available to people all over the world, that's great. Thank you very much.
More power to your elbow. Let's keep up the good work. All right.
Okay.
Have a good day, pal.
See you later.
See you now.
Bye.
Bye.